the trip I've been on the Regards trip, and also invite you to get on the bus with us. If you have things that you would like to do or questions you would like to raise, and you see this as a mechanism that might be useful to you, or if we have techniques that you might like to port into what you're doing, please feel invited to get involved either with us helping you or you coming and helping us. So what we've been doing is working on the causes for racial and geographic differences in stroke. So, I come here bearing good news and bad news. Okay? The good news is that over the last about 11 or 12 years, there's been about a 30–40% decline in the number of people dying from stroke in the United States of America. This is remarkable. I mean, this is beyond, much better than anything that you could ever expect. In fact, back here in 1999, I actually have a paper that is one of the ones I hope you never see, which is says that if the stroke has declined so much, it has to be over now. It can't go down any further. And so this is the proof of exactly how wrong you can be when you think good things can't continue, because good things continued. And it's so funny now because people are now discussing the Heart Association in particular is discussing it has to be over. We can't keep doing this, which I think is cool. The bad news is that's for whites, and this is the pattern for African Americans. And so basically it is also declining. But as you can see, there's about a 40% difference. In fact, if you look at the black to white mortality ratio, African Americans are about 40% higher than whites across the board. The guiding document for Health and Human Services, which includes little ditties like NIH as part of it, the Healthy Persons 2010 goals only had 2 goals. The second of which was to eliminate disparities. So how are we doing on eliminating racial disparities? Well, back in 1999, African Americans were at a 35% excess mortality. And we've eliminated that all the way down to a 45% disparity. So although it's going down for African Americans, it's not going down as rapidly for African Americans as it is for whites. Well, how about other races? Well, here's Hispanics, about a 20% benefit over whites. Here are, and it's very stable, 23% benefit down to a 23% benefit. Again, deaths from strokes. If you look at Native Americans and Asians, also a benefit compared to whites. And they're actually getting marginally better. For Native Americans, a 13 to a 22% benefit. So yes, sir. Thank you.
In the spirit of conversation, is that not potentially an art? Your figures on the right, that the percents are either not going down, or in one case at least gone up. Is that potentially an artifact of just using the ratio? That if you use the absolute risk difference, because as the things tend towards zero, assume you're dividing by zero,
Well, what David is bringing up is the absolute versus relative argument. And at least Health and Human Services made the absolute argument that we're going to eliminate the disparity. In other words, this line would come down to this point is what they hypothesized was their goal. And you are right, part of it is absolute versus relative. But to me at least, the fact that African Americans have a 45% higher chance of dying from stroke is not something we should be proud of, but something that we should work against. And anyway, so for Asians, they've also gone from 11% benefit to a 17% benefit, which, by the way, using Dr. Allison's relative versus absolute difference goes in the wrong direction for what he was pointing out mathematically. And so we're not doing well in eliminating the racial disparity. Now the disparity, so if you do talk about disparities in stroke, it's mainly African Americans versus anybody else. This is sort of the way it goes down. Unfortunately, that's the good news, because if you look at it by age, this is the black to white mortality ratio, Hispanic to white, Asian to white, and Native American to white. there's not a 40% excess mortality between the ages of 45 and 65, but a 200 to 300% difference in the mortality. When you get to be old, like me, or even older than me, the disparity goes away. And so really, if you look at the black to white mortality for stroke, it's about the second biggest disparity out there, coming in second mainly to homicide. There's a big black to white homicide difference. But after that, stroke, ages 45 to 65 is really one of the things that stands out as a major force. Well, so let's say that you're Republican and you don't care about people. All you care about is well, this is supposed to be a fun lecture. You know? all you care about is money. Okay. Well, so how much does this cost us? I mean, do we care about this in terms of? Well, between 1999 and 2007, when I made this slide, it's averaging about 6,000 extra stroke deaths every year in African Americans. But we don't care about stroke deaths, we care about strokes. And so you can back calculate the number of strokes by dividing by case mortality. And it turns out that that means there will probably about 25,000 extra stroke events in African Americans. I was brought up in a town of 8,000 people. So I think about 25,000 extra strokes happening in a small part of the population as being a lot of extra strokes. Stroke is expensive. It costs about $140,000 to have a stroke now. That's not the hospital cost. That's the cost of the hospital and the nursing homes and everything else that's associated with having a stroke. And so basically the cost of the excess stroke in blacks, not the cost of stroke in blacks, but the cost of excess stroke in blacks is running $3.4 billion a year, $3.4 billion a year. The regard study that you'll be hearing about, if we're successful in reducing the stroke mortality excess in blacks by 5%, the 5-year cost of the study would be paid for in 8 days. Okay, 8 days. And so we think of ourselves having a very cheap study. But really, I wish I had more time to talk about it, but strokes happen at very young ages in blacks. In whites, 25% of strokes happen below age 65. In African Americans, it's 44%. Huge differences in the distribution of stroke. And so if what you're talking about is somebody 45 years old having a stroke and being put in a nursing home for 30 years, they can run up a bill that is nothing short of staggering. I mean, it's unbelievable how expensive this is. So what causes it? Well, what people quickly jump to, well, to begin with, gee, we don't know a lot about this. Only in 2004 was there a paper that looked at black-white differences in stroke incidence. Isn't that amazing, 2004? The reason for that is where most stroke research is done is in places that only white people live and you plug in your car at night to keep it from freezing. I mean, it's like Minneapolis, Framingham, Massachusetts, other places like that. And so the research was not being done where black people were living. In 2004, the Greater Cincinnati study, wonderful study, Brett Casella, Don Hondorfer, published, and they said it looks like it's incidence and not case fatality. It's blacks are having more strokes. It's not that the strokes are more fatal in blacks. So it's just simply the volume of strokes in African Americans. Well, if it's the volume, it must be risk factors, and so people can't very quickly jump to the idea that it's because African Americans have more hypertension and diabetes, and African Americans have a lower average socioeconomic status, therefore less access to health care. And it turns out that the disparity has been going on for at least 60 years. That's as far back as there's data to prove that the disparity was there. I think it was there equally before then, but there's just no data to make that statement for us. So for more than a half a century, this disparity has been going on, and there's really very little data to address why. But what little data does exist suggests that SES, hypertension, and diabetes account for between 30 and 40% of the stroke difference. I wish I had more time to talk about that in particular. That's a fascinating topic. But if you think about it, African Americans aren't, in our study, 71% of the African Americans of hypertensive versus 50% in the whites. So the difference can only affect 20% of the people. And so you can't have a 300% increase in stroke risk by affecting 20% of the people very, very easily. But anyway, so gee, don't you wonder what is the other 60 to 70% of the black-white difference? Why does that exist? So moving on to another topic, don't y'all love living in Alabama? Isn't this a great place to live? So don't you wonder why, if you look at the geographic distribution of stroke, it looks like this. The dark purple areas are the areas that are eaten up with stroke. Up and down the coastal plain of North Carolina, South Carolina, and Georgia is an area called the buckle of the, this is called the stroke belt. Down here, up and down the coastal plain is an area called the buckle of the stroke belt. It's even higher than the rest of the stroke belt. And you know, you don't, people always look at this. Has anybody looked at the legend? How many people have looked at the legend? So y'all don't look at legends, so I do. And so here's the legend. And so the light purple areas are 50 per 100,000, and the dark areas are 150 per 100,000. Okay? And so basically you're talking about, again, a 3 times difference in the risk of dying from a stroke, just depending on where you live. Now, some time ago, we were lucky to recruit David Allison from New York City. We got David Allison to drive from New York City down through Tarboro, North Carolina, my hometown, and he ended up down here in Birmingham. But right now we're just going to focus on him coming from New York City to Tarboro. Beautiful town. Two PhD statisticians out of a little teeny town. Anyway, so if you believe Google Maps, that's 480 miles. You can drive it in 7 hours and 48 minutes. Okay? But during that drive, you'll notice that the stroke rate goes from 41 per 100,000 to 141 per 100,000. You know, so basically 243% higher over that little teeny weeny distance. And as you're driving, you should be thinking that your stroke risk is increasing 33% every hour that you're driving. Every hour you're driving, your stroke risk goes up by 1/3. Okay? And of course, it probably doesn't. We actually have a paper that says a person's stroke risk is higher while he's visiting in the stroke belt. While he's visiting in the stroke. But this might be true. It's a very hard hypothesis to address. But and just think, as you're riding by there and looking at people's houses, every hour the stroke rate goes up 33%. Okay? Even worse, let's say that you're driving from Palm Coast, Florida to Vidalia, Georgia. I couldn't resist saying what county Vidalia, Georgia is in. Toombs County, Georgia. I mean, how appropriate is that? Well, this is only 226 miles, a 3-hour drive. And during that period, you go from 60 per 100,000 to 150 per 100,000 in 200 miles, 300 miles. What was it I got? But anyway, so 150% higher, and so there you're going up 40% every hour while you're driving along. I mean, these are incredible differences in stroke. So what's driving the geographic disparities in stroke? Why are there geographic disparities in stroke? Well, what we don't lack is theories. The one thing we've got a lot of is theories for why the stroke belt exists. These are the 10 published theories for why the stroke belt. There's a paper on every one of these saying that this is contributing to the geographic differences in case fatality, geographic differences in lifestyle choices. For example, a lot of people think that the South is where people smoke cigarettes more. Matthew Loop in the back of the room is in the midst of proving that's wrong. It's down the Ohio River and down the Mississippi River. A lot of people think of Alabama and Mississippi as the fattest states in the nation. David Allison and I have papers out now that say that really what it might be is people from the South tell the truth more about how much they weigh rather than really weigh more. Okay, but there's, again, very little data to assess these. And this, using the same kind of backwards mathematics, is probably associated with an additional 21,000 stroke events and an additional $3 billion in cost. So going back to being a Republican, this means that you now spend every year about $6 billion on these two disparities, which is roughly 3/4 of the cost of a Nimitz aircraft carrier. And so basically, what you're giving up for the Republican congressman here is a brand new, nice Nimitz aircraft carrier every year. You could have a brand new Nimitz class aircraft carrier if you could just fix these disparities. Just fix it. Yes, sir.
Is there any evidence that there are any state boundaries?
The state values?
State boundaries to what was going on in that geographical thing, or does it leave
That's an
open?
interesting question. I'll back up and I'll point that out. There are a few state boundaries, but I'll argue there are fewer than you would think. And if you look at Virginia, this runs up into Virginia. If you look down here, this runs down into Florida. And so I don't see the state boundaries all that much. Okay, but anyway, so of these cases, the most commonly hypothesized reason is this differences in risk factors. It turns out Southerners probably are more hypertensive and diabetic. And so that is probably contributing some to these geographic disparities. But if you think it's risk factors, wouldn't you think that the places you die of heart disease would be the same places you die of stroke? Because after all, the list of dirty players is the same for both of those diseases. Well, this is the correlation between stroke mortality at the state level and ischemic heart disease mortality at the state level. These are almost significantly uncorrelated, if that makes sense. I mean, it's approaching being substantially statistically non-significant. Okay, 0.04. I mean, and it's fascinating. New York is always fascinating. Number 1 in heart disease, number 50 in stroke every year. And going back to the state boundary idea, you know, I've got this friend Tom Pearson. We drink a lot of beer and try to figure out why New York sits up there like that. And he said it's because of the way they're coding death certificates. It's because, you know, it's the way that they are, it's the record-keeping system. You know, here's New York, Rhode Island, Delaware, New Jersey, New Hampshire, Pennsylvania. There's the whole northeast corridor up there. Unfortunately for me, here's the entire South. Here's the entire Great Plains. It's great bathroom reading to sit and just look at that and see how these things relate to each other. It's really, really fascinating. So, you know, when is enough enough? Well, these disparities have existed for at least 60 years. That's how far back the data go. Few data explain it. If you want to know what's causing the problem, I'm sorry, if you want to fix the problem, you have to know what's causing it. You know, why are there not data? Why has this gone on for half a century and we haven't answered the question? Well, for racial disparities, again, most studies have been conducted in predominantly white areas. Probably the greatest exception to that is a wonderful, wonderful study called the Northern Manhattan Study, run by Ralph Sacco. And he has blacks, whites, and Hispanics in a cohort. But he only has about 3,000 people in his cohort, and New York is really weird for stroke. New York City, of the 3,000 counties in the United States, 5 of the lowest 8 of the 5 boroughs of New York. I mean, that is remarkable clustering at the low end of the spectrum. 5 of the 8 lowest counties of the 5 boroughs of New York City. Well, how about geographic disparities? Well, here the challenge has been we really need national studies designed to contrast differences between regions. Well, why has that not been done? Well, probably the best study is N. Haynes. I'm assuming y'all have heard of N. Haynes' National Health and Nutrition Examination Survey. Did I get that right? People might not. Anyway, but that's really focused more on describing regions and not differences between regions. And so it's not really designed to answer the question that we're interested in. We're not interested in what is the stroke rate for the United States. N. Haynes is great at that. We're interested in what are the differences between regions. So what's needed to understand this? Well, what we need is a national observational. It's hard to randomize to race or region. I mean, we can't say we're going to randomize people to be black or white, so we're going to be doing observational studies. But a national observational study, because stroke is relatively rare, it has to be huge. And that's how we got into the regards. We back calculated before we got started and said we need about 1,000 stroke events. And back then we needed about 5 to 8 years of 30,000, following 30,000 people to get 1,000 stroke events. So that's where the miniature would get to the regards 30,000, that's where it came from. And it has to have heavy representation of African American, and it has to have a control group. And for us, we include whites for our racial disparity only because we need somebody to compare African Americans to. I think Jackson Hart, Herman Taylor's a dear friend of mine. Jackson Hart's a great study. They're studying 6,000 or 8,000 African Americans, but there's no control group. And so at the end of the day, what they're going to find out, in my opinion, is that African Americans who are hypertensive and diabetic and smoke cigarettes have heart disease and stroke. But we sort of already knew that before we got started. The question is, what is the difference? Okay, so how do we get into this business? So I want to back up, and so here's my history lesson. So the beginning of modern cardiovascular epidemiology, this is the Boston area, and of course just in the Boston area there's this little town called Framingham. And back in 1948, the Heart, Lung, and Blood Institute basically walked into town and measured, well, this is on the next slide, 1948, they established a clinic, the town's about 5,000 people, and they had residents come in to be evaluated. They've kept that clinic active now since, what were you doing in 1948? But for a very long time, we're going on 70 years of the Framingham study. People come in every 3 years to be evaluated, and they identified incident cardiovascular disease, heart disease, and stroke. It's the incident risk factors and looking for change in risk factors. By the way, Framingham is where the term risk factor was coined. That was the study that first used the term risk factor. But the paradigm of the study is the longitudinal cohort study where we identified most of the risk factors. We developed risk prediction models. We actually, again, as I said, coined the term risk factor. And subsequently, the Framingham study gave rise to this paradigm of a clinic. I'm going to bring people into my clinic, and I'm going to evaluate people in my clinic. And that paradigm has gone on for a long time.
George?
Yes?
Just for context, I mean, I know how the Mayo Clinic ended up in Rochester, Minnesota. How did they end up in Framingham?
I honestly don't know. Does anybody know?
Anybody know?
You did?
There was an earlier TV study there.
Okay, so how'd they end up in the TV was prevalent there, and that's where they picked it, or?
Yeah, I think so. And they thought it was diverse because there were German Americans, Italian Americans, and Polish Americans.
It was Northern European diverse.
Yes.
Well, this, by the way, is a lily white town.
Yeah.
I mean, it is
Northern European.
incredibly lily white town.
Okay.
Okay, but basically, following
George, can
that
I just
paradigm.
add one thing? Literally, it was just two researchers.
Right.
Is that
Anyway.
random?
Yeah. But anyway, so the studies it coined were Cardia, ERIC, and CHS. These are, again, heart, lung, and blood studies. Cardia looked at people under 45, ERIC 45 to 65, CHS older than 65. Of course, Birmingham, UAB is one of the Cardia sites for both the clinic and the coordinating center. They have special populations such as the Honolulu Heart Study, the Jackson Heart Study, the Hispanic cohort, and Hispanic community. I've forgotten what it stands for, but the Hispanic study and studies of risk factors. But all of those use the paradigm of let's get a clinic and let's bring people into the clinic. Well, this Framingham paradigm has big advantages. The big advantages is that, first of all, you get to do a longitudinal cohort study, which is probably among the observational studies, the gold standard among epi studies. The participants' identification can identify with the study, and that really helps with retention. That they get to know each other. Most importantly, it allows incorporation of complex evaluations of subclinical disease, intimal medial thickness, how thick your carotid arteries are, coronary calcium, how are you developing calcium, and that allows a reduction in the sample size. And the control of the clinic really allows high-quality data to be collected. I'm not slamming the Framingham model, great model, but it has disadvantages. And the disadvantage is the cost is really tied to the clinics. If you want to do a national study with people from everywhere, you're going to need tens, if not hundreds, of clinics. And clinics have MDs in it, and MDs are expensive, and the cost of the study goes through the roof. Okay? So it requires, and because of that, because it's expensive, it requires reliance on subclinical disease. I was one of the ERIC investigators too, and I remember until, for the rest of my life when they said we're going to study 15,000 people in ERIC. And it was just an amazingly big number. But even with 15,000 people, you're forced into having the primary outcome of the study not be events, but how thick your carotid arteries are, the walls of your carotid arteries are, and how you're developing atherosclerosis is measured for subclinical measures. They've gone on and done coronary calcium afterwards. Well, I don't really care if I have thick carotid arteries, as long as you promise I won't have an event. I mean, it doesn't bother me at all to have thick carotid arteries, and so it's better to go after events. It limits the ability to address novel hypotheses such as interaction and mediation. Again, this is tied to the statistical power. And also, the big thing is you have geographic restrictions. It limits your ability to generalize to national populations. And so what we as a group of people wanted to do was find a way to get a national study without using the Framingham paradigm. Well, other people had that same idea. How do we break the Framingham paradigm? How do we get rid of the clinics and do a national study? The cool thing was, the first cool one was provide the ability to move the clinics. In other words, let's don't have a clinic be fixed. Let's be able to move our clinics around. And the great example of that, of course, is in Haynes. In Haynes, their clinic is 4 semi-trucks that come into a town and connect up, and it makes a clinic. And then they stay there for a month or so, and then the 4 semi-trucks go to another town. And so the clinic moves around. And that allows to be able to get more of a national sample. But it also has disadvantages, and it can dramatically increase the number of sites, but it also reduces the problem I'm sorry, that's an advantage, reducing the problem of generalizability. The disadvantage is, at the end of the day, you're still limited in the number of sites that you do. A lot of people are surprised that in Haynes usually only does about 82 sites in one of their waves. And so you're not getting, it's representative of the United States, but talking about differences between these 82 towns is very limited, very limited. So the second attempt to break the paradigm is to get rid of the clinics altogether. Avoid doing clinical assessments. We can do this remotely, and the best example of that is the behavioral risk factor surveillance system, where basically it's the largest health survey, I believe, in the world. They do 300 and some thousand people are interviewed every year. They call people on the telephone and ask them questions. It is cross-sectional. They don't call these people back. But it does allow you to really generalize. They can get a real national sample of this. It again has advantages and disadvantages. The advantages, you can be huge. 300,000 people is really pretty cool. It's really pretty cool. But it has the disadvantage of being self-reported. You know, if you call up and say, do you have undiagnosed hypertension? That doesn't work very well. I mean, you know, are you diabetic but don't know it? That does not work. And also, at least for BRFSS, it's cross-sectional, but you can fix that if you want to. So anyway, the third attempt to break this is to avoid clinics. See, all these people are trying to break that paradigm, So the third group of people wanted to do it by avoiding clinics by using special populations. And the best example of that is the nurses' health and the physicians' health study. Where basically the baseline and self-evaluation of the cohort is done only of physicians and nurses, and they basically examine themselves. So basically it's a national sample of nurses or physicians. And again, the advantage is you can get a large geographically dispersed cohort that can really be very efficiently monitored. But the disadvantage is, well, you're studying doctors and nurses. And so, how representative are doctors and nurses? So what I wanted to do very quickly was talk about how we tried to break this, and this is moving into regards now. So basically there are these immense and geographic and racial disparities. Understanding is poor, and our goal was to develop a cohort of sufficient size to allow novel hypotheses. We needed about 1,000 strokes. That means we had to get a cohort of 30,000 people, which by the way had to be funded by the Stroke Institute, which is a little teeny institute compared to heart, lung, and blood and cancer. And so you had to be very efficient. And so that required remarkable study efficiency. And we wanted to provide geographic heterogeneity with oversampling of the stroke belt in African Americans. And so basically, what did we do? Well, what we did was we called a commercially available list. By the way, it's the same list that BRFSS uses. You've always worried about Big Brother knowing too much about you. Big Brother's name is Equifax, and he does know too much about you. It's amazing what he knows about you, okay? And so basically we purchased the list, we sent out a letter, said stroke is a terrible problem, would you like to help us? We'll be calling you in 2 weeks. 2 weeks later, Paul Wolf here called 30,000 people 2 weeks later to see how they're doing. And if they said, they called and said, stroke is a terrible problem, wouldn't you like to help us? We were amazed that about 33% of the people said, sure, I'll be glad to. Our participation rate is 33%, which, by the way, is really cool if you're in this business. I'll ask you if you picture yourself being at dinner and having somebody you don't know call up and say, would you like to be in my health study? And a third of the people said yes. So we're sort of not in apologizing mode for getting a participation rate of 33%, particularly women, where we say, what we want to do is to by the way, let me get to that. So what we did at that point was do a caddy interview, about a 45-minute interview. One of the great shortcomings of Regards is Eric and CHS have about a 2-hour interview. Nobody will stay on the phone for 2 hours. Okay, so we had to go from a 2-hour interview down to about a 45-minute interview. A woman named LaVon Pulley we worked with said you cannot go past 45 minutes. If you go past 45 minutes, it's like walking off a cliff. Everybody just quits, okay? So we had to take a 2-hour interview and turn it into a 45-minute interview. It was the most bloody meeting I've ever been a part of. I mean, everybody has their favorite questions. And so there was this huge battle about what questions get to stay and what questions leave. The trick of Regards is we then partnered with a group of people who do life insurance physicals. Examination Management Services Incorporated. This is a wonderful company. They have 6,700 examiners, mainly nurses, spread out pretty evenly across the United States. And for a very reasonable amount of money, they will send one to somebody's house to do an evaluation. So what we did is we went into the home. In the home we did height, weight, waist, drew blood, got urine, put the people on a scale. I said that already because I said weight. We went into their medicine cabinet, wrote down everything they were taking, all the medicines they were taking. And we left a self-administered questionnaire, which we were amazed 92% of the people mailed back, which is really pretty good. The blood from the in-home visit went to the University of Vermont, dear friends up there, Mary Cushman. The ECGs went to Wake Forest University. We then called the people every 6 months to see how they were doing. Initially, just to find out if they've had a stroke. Okay? Ancillary studies have broadened this now, so they're also finding out about MIs and venous thrombosis and fractures and cognitive change and a lot of other outcomes on this. But if they have a stroke, what we do is then go after their medical records, bring them back here and have them centrally adjudicated by a board of physicians, primarily board-certified neurologists. So what do we do? Well, again, we needed about 30,000 people. We ended up with about 30,000 people, age 45 and over. We wanted to get half from the stroke belt and half from other regions. We got pretty close. We wanted to do half black, half white. We got pretty close. By the way, recruitment of African Americans is always a challenge in studies like this. And so this 42% of 30,000 people is 12,656 African Americans. And so if you want to do just a study, do analysis of just African Americans, this is one of the largest cohorts of African Americans being followed longitudinally for the study of any disease. If you throw away the whites and just look at the African Americans. So our cohort of African Americans is twice as big as Jackson Hart, which is the commonly acknowledged African American study. We wanted to do half men, half women. Men are also a pain in the patooka in these studies, and so we ended up with more women. And this is where our participants are from. And so it's basically, you can see the oversampling of the stroke belt. The blue dots are the African Americans, the red dots are the whites. The single county with the most people is Los Angeles County. That's because Los Angeles County is the single county with the most people. There are about 1,000 participants from Los Angeles County. One of the interesting things to me, at least, is if you look at this, you see rural southern blacks, but once you get out of the South, there's no such thing as rural black, and very few rural blacks in other regions, which really complicates the analysis and interpretation. So what kind of data do we have? Well, we have what you'd expect us to have in a study like this, and what we hope you'll use with us. So questionnaire data on risk factors and quality of life and depression and stress, a good lab profile, ECGs, self-administered data on diet and family history, follow-up for incident stroke and enlightenments. We also have the reason I wanted to talk to you is so we also have novel data that we hope you can use. Remarkable geographic heterogeneity. We think of ourselves as being, really neat to be. For example, one of the goals of NIH is to look at rural research, rural health. There are very few studies that actually have people from rural regions because most of the tertiary medical centers that ran the cohorts tend to be in big cities, and so the cohorts are in big cities. We have longitudinal cognitive assessments. One of the cool things that my wife is interested in is residential history. Where were you born? Where did you move after that? Where did you move after that? And it basically allows her to calculate the moral equivalent of pack years of exposure to living in the South. But a lot of other funny data. What we don't have is, again, bloody fight over the interview, so we don't have as much interview data. And we don't have anything that's complex because there is no home MRI machine for us to go in and do MRIs. I'm running longer than I wanted to, but these are the studies that tell us the most, that we've learned the most about stroke. For the statisticians here, it's not the size of the study, but the number of stroke events is where the power comes from. Already we are much bigger than any of the other studies. We've already had about 1,100 strokes. We're funded through 2017. We'll probably have about 1,700 strokes by then. This is the age distribution. We think it's cool that 14,000 people are age 65 and over. So CHS, the study of the elderly, is 6,000 people over 65. We have 14,000 people over 65. In fact, there are sub 5,000 over 75 and about 600 over age 85 in the study at baseline. So the conclusions of the regards are we've met our goals. We've got a national cohort that's drawn from 1,800, it should be 66 counties. 1,866 counties from about the 3,000 counties. So about 60% of the counties we have somebody from. It's big enough to allow novel hypotheses. The cool thing about the study is using this approach we were able to recruit, evaluate, and follow people for 5 years for $800 a person, which is, in this business, dirt cheap. We oversample blacks and stroke residents, but we have advantages as we're well positioned to provide insights to these disparities. And the disadvantage is, we admit it, we don't have the tight quality control that a cohort study would have. If you have 6,000 examiners, you're not going to control what 6,000 people do as well as if you have a clinic in your own. Well, if you build it, will they come? This is the other things part of the lecture. Well, now we have a national longitudinal study, and we think of that being a remarkable resource, and we think of it as being a duty to share our resource. The study has received 138 proposals for ancillary studies, which we think is pretty cool. Of those, 31 are funded and active, and these are mainly NIH ancillary R01s that have been funded. 2 have been funded or in startup. We have 9 currently under review. Interestingly, 20 are completed or incorporated, so if you add those together, about 50 have been done. 50 of the ancillary studies have been done, which is more than the number that haven't been done. So our funding rate for ancillary studies is way above 50%. Because that 44 includes the ones that ended up not being submitted to. And so we think that's pretty cool. What are the ancillary studies? I'm going to fly through this. We've added new outcomes like coronary events, fractures, venous thrombosis, sepsis, end-stage renal disease, We've added other outcomes such as caregiver burden for stroke survivors, chart abstraction for the quality of care in these stroke patients. We have new exposures, measures of kidney function. We've mailed out accelerometers to the people to measure physical activity and brought them back in. We have measures of occupational, a really wonderful measure of their occupational experience. Childhood socioeconomic status and quality of education and different trace elements. We've linked the data set with other data sets. Leslie McClure here has what I think is one of the cool ones. She linked our people to the NASA measures of air pollution. And so she has satellite measures of air pollution on the people. Virginia, my wife, is linking it back to census data going back to 1900. I didn't realize this. Censuses that are 40 years old are no longer confidential. So you can go back and say, I'd like to see Bill Smith's census record. And it's a matter of public record. I forget whether it's 40 or 50 years, but sometime in the past you can go back and say, I want to see, not the raw number, I want to see the form that was filled out, which is a cool thing. A lot of expanded analyses to do different things, such as diet, where we've got funded by General Mills to do that. There are a lot of genetic studies going on. All the African Americans, the DNA has been extracted. A lot of GWAS activity is going on in the African Americans. We have a lot less interest in our white DNA than our black DNA. So we're also very proud of our publication record. This is the number of papers published out of the study, which as you can see. It's interesting, when we got started, we were prohibited by the Institute from publishing. They said you cannot publish out of this until the cohort is in place. And so back here, we were literally prohibited from writing papers. And 2007 is when they finally said, okay, you can write a paper. But as you can see, the growth in the number of papers. One of the things that we're very proud of is that 70% of the papers out of the study are first authored by people who are not part of the parent study. Anybody can write a paper here. We'll do the analysis for you for free, as long as you promise you'll write the paper. And so basically the blue lines are the papers that we've written of investigators. The red are ones that have to do with our hypotheses but were done by somebody else that is not part of the study. And the green are things in other diseases like sepsis or kidney disease or other things that we're not really interested in. We're also right now in the midst of a second risk factor assessment. It started in May of 2013. We're going back into everybody's home. David Rhodes here is leading the effort of organizing that. It's about 10 years between the assessment, and what we're interested in is how the risk factors have changed over a decade. We also have new measures like chair stands and time walks and health literacy assessments. We have new self-administered questionnaires on neighborhood perception and discrimination and life space. Specific aims are really related to incident risk factors. It's amazing. Of the people who were normotensive 10 years ago, about 45% are now hypertensive. And the risk of becoming hypertensive is twice as high if you're African American than if you're white, and it's not related to the age. So if you're a normotensive black who's 75 years old, and you're a normotensive white who's 75 years old, the 75-year-old black is twice as likely to become hypertensive as the 75-year-old one. So basically, we've had about 7 years follow-up. We're doing okay. 14% of the people have died. 21% have withdrawn from the study. We anticipated about 3% would drop out. We're within that range. Completion of expected follow-ups was about 80%. We've done about 6,700 second assessments already. And the refusal rates, we will admit, are a little bit higher than what we thought they would be, but not horrible. So the future plans are to continue, basically. Try to maintain the cohort, try to complete the second risk factor assessment, try to publish and present, and try to develop ancillary studies, hopefully with some of you, to enhance the value of regard and encourage participation, and to continue with new investigators to look at the data set. Of course, that would be incredibly inappropriate if I didn't thank NINDS, who is funding the parent study. This is a group of people who don't really know or understand epidemiology, and so for them to be doing this with us for now 14 years is a remarkable commitment that we appreciate. And we thank the investigators and the staff, and most of all the participants, the wonderful, wonderful participants who are doing this with us. And I'll stop now. This is the team that's trying to do this, a little bit of a dated picture. And with that, I'll stand for any questions.
So I want to go back to one of the statements you made earlier, that you can't randomize people to geography or race. And I would say that depending on how strict you want to be about defining randomization, that's not true. So adoption studies, when people are adopted, if they are adopted to different geographic areas, they've sort of been randomized, assuming those assignments. So there's something called a Holt adoption study that you could look at that has over 1,500 Korean children who are now adults, who were adopted into various states in the United States. And you can see if they get different stroke rates in different places.
I agree. I guess my definition of randomization is perhaps a little bit tighter than yours. But I bow to you, they can be pretty random processes, we'll call them, that put people in different places.
And the other one is race, so that if Mendel was right, of course we know he wasn't strictly right, but if he was, then conditional upon the parents' genotypes, the genotypes that the offspring get are random. And so you can look at degree of African admixture conditional upon parental degree of African, or just degree of African ancestry. And then you have randomization to a greater genetic component of one race or another.
Right. It's interesting how we define races by self-report. It's so funny, there's a great question called the general health question, rewinding a little bit, which was initially, I understand, created as a softball for somebody to throw somebody an easy question before they got into hard questions. So the question is, compared to other people your age, how would you rate your health? Very good, excellent, very good, good, fair, or poor. And this was supposed to be an easy question for people to answer. And it turns out it is the single most predictive question of bad things. If you say you're poor, your health is poor, you're going to die. You're going to have strokes, you're going to have heart attacks, you're going to have car wrecks, all kinds of bad things. And so, I was telling people that if you think your health is poor, whatever you do, don't tell anybody. Because if you say your health is poor, you're going to die. Well, our definition of race is self-report. And so basically, if you say you're African American, your risk is 3 times greater to die from stroke. So I guess if you're African American, don't tell anybody that you're African American, because if you say that, you go 3 times higher risk of death. So basically, I think our definition of race is self-report, and I think that would be hard to randomize. Your question about admixture is really interesting, because we have looked at the admixtures, and it really just lines right straight up with stroke risk. For people who aren't aware, there's a surprising, at least to me, amount of admixture among African Americans or people who self-report being African American. It goes from 50% African American up to 100% African American. And if you look at stroke risk across the genetic breakdown, it increases with very linearly with the genetic measure of African Americanness.
The key would be to do it conditional upon the parents' admixture.
Mm-hmm.
That's the trick to make it randomized.
We can't do that, but that's a great idea. That's the study you should do. Any other questions?
Sure, I found the map very interesting in terms of the relationship of Alaska and where it lied with the rates up there compared to the other, just in close proximity of Washington and some of the other states that are nearest by, just because the northern part was, I guess, in the high range compared to the lower 2/3 of the state or whatever, and then the other. Is anybody looking at that and why that's so?
The Alaska
Right,
routes?
yeah, it just looked to be such an
Well,
anomaly.
we're not looking at Alaska or Hawaii. It was a hard decision, probably a mistake that we made, to not include Alaska and Hawaii. We didn't include them because there were no blacks, not a substantial African-American population in Alaska and Hawaii. And also, we're interested in sort of geographic dispersion, and there's not any United States next to it, and so it didn't make sense to look at the difference. If we'd done that, we would have only sampled, we ended up calculating 50 or 60 people additionally to include Alaska and Hawaii, so it wouldn't have cost us anything, and then we could say we're a national study. But we're not a national study because we just Hawaii and Alaska. There is a study looking at Alaska natives. David probably knows more about it. Do you know about it than I do?
Well, Haymont and I'm very involved in that. It's not that big though.
Yeah. And as far as Hawaii, probably the pivotal study on that was the Honolulu Heart Study, which was done in the 70s and 80s. And I don't think it's active anymore. I could be wrong. Dwayne Reed did. That doesn't sound right. His last name is Reed. Anyway, Reed did that. The most interesting thing on the Asians is I'm going to mess up the name of the study. Somebody please correct me. Hassan Min study, which studied Japanese people in Japan, Honolulu, and the United States. And it turns out that if the Japanese in Japan all die of stroke, Japanese in the United States all die of heart disease, and people in Hawaii are exactly in between. So it's sort of like the Japanese man meets McDonald's.
Related,
You have time for one more?
yeah, so related to that question, have you guys tracked it, what happens when people move?
We do. It's fascinating. Again, this is mainly Virginia's work, and it's so fascinating to me. So what she did was look at both hypertension and stroke risk as a function of how old you were when you lived in the stroke belt. I've got great news for all the people who are not from here but have come here as professionals, which is that what she has found is that the strongest association with both hypertension and stroke risk comes from where you lived when you were like 13 to the early 20s. And what she says, not me but her, is that this is where you're deciding to sit on the sofa and watch people play football instead of going outside and playing football. That's what you're deciding at that age. And so if you were recruited to UAB, so Dr. Allison has come down. He was way over 24 years old when we got him, and he left New York City with the lowest stroke mortality in the United States. And so Virginia's guess is he's fine, he's going to be cool. I came from Edgecombe County, North Carolina, which is always one of the top 5 counties in the United States in stroke, always. I came here, and I probably brought that risk with me because that's where I was when I was.
You talk about stroke as kind of this model, but I mean, could you distinguish between ischemic and hemorrhagic in the population?
Right, it's interesting. Yes, we have our people, I love the word subtyped. But all of the stroke mortality data is on all stroke together. The clinicians who complete the death certificates and the coroners who complete the death certificates generally do not distinguish between stroke subtypes. Over 50% of the strokes that are coded in vital statistics are coded as stroke NOS. In other words, it was a stroke, we ain't going to tell you what. And so basically that's the reason why things like the Framingham stroke risk function is a risk function for all stroke, because that's the way mortality is reported. We're getting more and more into stroke subtypes, and in fact, we're very excited. We have, I think, about 120 hemorrhagic strokes, which are precious things to have. Well, for us, precious things. Boy, did that ever come out. It's precious. These people are really informing the understanding of hemorrhagic strokes, and we actually have written a paper that developed a risk function for hemorrhagic stroke, which is, there aren't a lot of those around.